Thank you, everyone, for joining us for another Learning Lunch hosted by Format Approved. My name is Brian Johnson. I'm the Senior Director of Online Education with Format Approved, and I'll be your moderator today. Today's Learning Lunch title is, Are You Prepared for a Meaningful Use Audit? We're joined today by Todd Searls, the Executive Director of Wide River. Todd has a wealth of real-world experience in health IT and meaningful use, including experience with Nebraska's Regional Extension Center and a variety of other experience. You couldn't ask for a better expert to advise you on meaningful use and the possibility of an audit. It's our honor to share Todd's expertise with you today. Thank you for joining us, Todd.
Thank you.
All right, well, before we begin, I'm going to go on to the question and answer slide to give you an idea of what we're going to address today while I go over some quick housekeeping notes. Remember that you can ask questions of our presenter at any time during today's session by entering them into the chat area. We're going to hold those questions till the end of the presentation, and then we'll address as many questions as time allows. If we run out of time and we don't get to your question, we'll send those on to our presenter, and he can follow up by email after the event. Also, remember that all registered attendees of today's session will receive an email with links to both the slides and the video recording. So we often get people asking us if they can get a copy of the slides. We will provide those to you after the event. All right, well, let's begin. Again, thank you for joining us, Todd. It's really a pleasure to have you with our Learning Lunch audience today. To begin, can you give us some background on the meaningful use audit process?
Absolutely. I think most everyone on the call is probably familiar with, the HITECH Act, and when meaningful use first came out, there was a lot of concern on both sides of the aisle in Congress that, of course, billions of dollars would be paid out, and they wanted to ensure that there was going to be adequate oversight, that providers and hospitals that were participating in the program were doing so, of course, according not only to the spirit of the rule, but also the letter of the law. And so what we have, since learned as this, as the years go by and the audit process starts to evolve, is that there are now two processes. There's a prepayment audit and a post-payment audit. And we'll kind of go into some of those details in future slides. But as a background, when the audits first started, it was only post-payment audits. So you would have a provider or a hospital that went through the meaningful use program, attested to the program, received their money, and then, Figliosi and Company is the audit group that was contracted by CMS to perform these audits for Medicare, and they would send out a letter and say, you received money back in 2011 or in 2012 for your attestation. We now want to verify the fact that you have all the proper documentation and that you did so according to the letter of the law. And that was a very rocky road. People didn't understand why one provider in a practice was chosen versus another. They didn't understand if one provider is being audited, did that automatically mean that every provider in that same practice was being audited? And so over time, we've had a much better understanding of how CMS and then the respective states for the Medicaid program, because they're the ones responsible for auditing those, we've seen a much clearer picture come forward. And that's not to say that it is a very clear picture, because it's still cloudy on the edges, but we have far more information than we did. And so just very briefly, the audit process really, it has boiled down to this. If I'm a provider or a hospital participating in the Medicare program, I'm going to go through my attestation process, and for the next 6 years, I have the possibility of being audited. And you will receive a letter to the address and NPI, that was associated to the NPI number through your attestation. And the letter will state that you've been selected either for a prepayment audit or a post-payment audit. And then they will follow up with you with various questions and requests for certain documentation. In a nutshell, what we're finding in the field is that they're asking for everything except for CQMs. So on the prepayment side, you basically have to make sure that you've got a volume of documentation that is clearly labeled, clearly laid out, and really good to go. And then on the Medicaid side, if we look at this, it's really up to your individual states. Some states, for instance, where I live here in Nebraska, they kind of came out of the gate later than a lot of states, so their process is still evolving. But in other states like Oklahoma, perhaps Iowa, that were some of the first ones out of the gate, they have, I think, a more established process. And so definitely if you're a Medicaid provider, get with your state Medicaid officials who are in charge with the incentive program and make sure you understand their process before it ever begins. And so that's really it. You know, you have the ability, if you fail an audit, to appeal. But I think everybody knows if you're going to take, obviously, the government's incentive dollars, you have, you know, to expect the fact that at some point they're probably going to come in and audit you.
Well, how concerned should providers be? How likely is this to happen?
Well, you know, once again, as with you know, just the background of the program, we've seen this evolve. Initially, when I was back as the director of the Regional Extension Program in Nebraska, we heard quite a bit from CMS directly that stated, you know, we could see 5% of providers who would be, you know, selected for an audit, whether or not it's a prepayment or a post-payment audit. We're actually seeing those numbers increase quite a bit. And I know that Steve Spearman from Health Security Solutions submitted a Freedom of Information Act, got some information on the meaningful use audits that have gone out to date. And, you know, if we look at just post-payment audits, since probably the middle of September, there have been approximately 5,000 providers that have been audited. Of those, about 96% have been completed, so there are still some post-payment audits out there. And on the prepayment side of things, it's almost 6,000 providers have been sent audit letters to look at their, you know, 2011, 12, or 13 years of attestation, and approximately 65% of those are completed. So we've got 2,000 audits that are currently ongoing right now, and we tell all of our clients, you know, as everybody in this field has stated, you know, if you're a health IT consultant working with CMS, you know, it's not a question of if, but when you're going to be audited. So you may not be audited for 2011, you may not be audited for 2012, but possibly in the future, after all the incentive payments have gone away, and you're attesting to meaningful use to skip penalties that are going to be coming down the pipe, you can bet at some point you're probably going to receive an audit letter. And to make sure that you're actually still participating in the program according to the rules. And the failure rate, as you see from this slide, especially if you're on the eligible professional side of things, is concerning. You know, and this is exactly why they're auditing. And the higher this failure rate is, the more likely we're going to see them ramp up and pay for more auditors to go out and ensure that they're capturing, you know, that everyone's doing this appropriately. So I would put, you know, in terms of a risk rating on a concern level, I'd put it at about a medium to high. You know, definitely very high before you ever attest to make sure that you've got all of your I's dotted and your T's crossed. But then after the fact, especially when given staff turnover in some of our smaller clinics and even our larger health systems, you know, it is critically important that you maintain accurate documentation and your knowledge sharing and passing that knowledge on. So when the audit letter hits, you don't have somebody who's just been on the job 6 weeks and has no clue what was done, you know, 5 years ago. So I would definitely place this as a moderate high risk if you think you're doing everything perfect, and I put it at a very high risk if you don't really have a good handle on your process.
Well, that's great advice, Todd. You know, we do a lot of HIPAA learning lunches and training at Format Approved, and one of the things we tell people is your chances of getting audited for meaningful use are much greater than they are for HIPAA just because of the numbers involved. They're just doing many, many more audits for MU than they are for HIPAA. So on the HIPAA side, if you have a breach, you're going to get investigated, but your chances of getting audited are relatively low. But for meaningful use, they're not low at all. They're relatively high.
Yeah, absolutely, and especially now that they're implementing the prepayment. You know, it's one thing I think after the money went out, and they were trying to ramp up the program initially, and so a lot of providers with this initial crush of attestation, where we had 40 to 50,000 providers attesting early in the program, it was overwhelming to CMS to try to ramp up a really robust audit protocol. Now, however, they've ramped that up, and they've got methods and processes in place, and it's much easier for them to continue to build on that than it once was. So I absolutely agree. Meaningful use is going to become one of those things that, especially I also think at the state level, where there is such a concern for Medicaid dollars in this political climate, that people are going to be scrutinizing the money that goes through that program very highly. And when we hear a lot of times providers say, well, if the risk is so high, then it's just not worth it. Don't look at it that way. I mean, really don't look at it that way, because if you're doing what you know is right, then you really don't have anything to fear. The good news is that when we work with most of our clients, even those that fail the first audit, it's usually because they didn't organize their documentation well, they didn't clearly explain what it is they were sending in, or honestly, you don't know what you don't know. And a lot of times the auditors will ask for documentation. We're going through a review right now with a client in which they sent in proof of access. They showed the fact that their EHR reported, the fact that here are the meaningful use reports outside of the EHR, here's the chapel number, and the auditor came back and said, basically, that's not proof of access. What we need for proof of access is a letter from your vendor stating that you actually have this contract in place. And to those of us who've been around, you would look at this and say, I've given you everything you realistically need. Why would I now need to go back to the vendor? And what they found was initially when people were giving chapel numbers, the chapel number was incorrect. That chapel website, if you're not familiar with it, to add especially multiple EHR products, if you're using modular EHRs to the cart and coming up with a custom number, wasn't exactly the most clearly defined process. And so people stumbled with the wrong chapel number in. And then in terms of screen prints, showing the version number that you're using, they actually caught people copying, screen prints from other providers. And so they were definitely taking advantage of the system. And so those of us who are 99.9% of us who are pursuing this legally, accurately, unfortunately when it comes to audits, we have to suffer the processes for those people who have tried to take advantage of the system. And that's why they actually want a letter now from the vendors. But those are things that, hopefully as word, like these webinars that FormEd approved is hosting, this word will spread and it'll become an easier process for everybody. But it is a high risk.
Absolutely. So when it comes to leadership and meaningful use, what do providers need to keep in mind?
The very first thing we tell providers, and this is, again, it doesn't matter if you're a one-provider practice or a 300-provider multi-specialty managed service organization or an IPA, you have to empower the people who are performing your meaningful use functions. You have to give them the authority to track down, make changes, track down problems inside of the meaningful use processes, to make workflow changes, to recommend even business changes so that you're capturing all of the right data elements and you're also obviously meeting meaningful use. And that is very clear when it comes to the security risk assessments. A lot of times we've run into it where cost drives process instead of process driving what you invest in. And this is not something that people should be trying to do on the cheap. And when you have good people working for you making good recommendations, but those recommendations may come with a price tag, we've seen too many times that the good opinions of these people are just immediately discounted. And that gives a high level of dissatisfaction for those people who are trying to keep you legal. And it also is a high level of dissatisfaction for the providers when ultimately, if the lack of investing in their processes turns into a failed audit and they have to give their incentive monies back, it's not a good thing all the way around. So I would say, again, empower people that you trust to lead this program. Make sure that you have clinician buy-in. I mean, make sure everybody understands that even though in the provider space, the individual provider is the one who could be audited. Again, as I referenced earlier, one provider could be audited as opposed to the entire practice. But everybody should believe that they're all in. And if you have a hostile clinical environment that is against meaningful use, then whoever you put in charge is going to have a tough road to hoe. And nobody is doing this inside of your practice to make it worse for everybody. You know, everybody's trying to help out. So we really do. I mean, there are so many times when we engage in the field with practices and we see that the people that have been put in charge of meaningful use are respected leaders. Those practices will thrive. When someone was put in charge but not given any power or authority, especially in the clinical space, those practices are the ones that routinely fail. And, you know, so that's what I would say. Make sure your leaders are empowered to do what needs to be done. And then if you have a group, especially these larger ones, make sure you're coming together frequently and everybody understands. Too many times we go to a multi-site, or whether or not they're a single specialty or multi-specialty, where a steering committee will put forth one plan, but then when that plan gets disseminated to multiple sites, the site leaders, perhaps the office managers, perhaps the physician champion at those sites, they basically say, no, we're not going to do it that way. And that breaks the process down and puts everybody at a higher risk of you know, a failed audit. So definitely that goes into culture, and make sure you overcome, as I state here, those culture issues before those culture issues overcome your bottom line.
So you already talked some about documentation and how important it is to, you know, keep that documentation. What are some things that providers really need to keep in mind about the continued documentation?
Yeah, you bet. I think, you know, a lot of this conversation that we'll have today will bleed over multiple topics on the slide, but too many times we go into a practice, especially if they're using a cloud-based vendor, and they'll tell us, well, yeah, we attested, we've got all the documentation, we've got the reports, but we can reproduce the documentation at will from our vendor's system. So we're not too worried about keeping, you know, quote unquote, the binder full of information, and we have to caution them. Can you guarantee that when your vendor goes from the 2011 certified EHR to the 2014 certified EHR to the 2015 certified EHR and beyond, that you could go back 5 years earlier and reproduce the exact copies of the report? And I would say 99.9% of the time that's not going to be possible. Now, some vendors are creating environments where they're creating static snapshots. So you just need to work with your vendor to make sure that you know for a fact, if you're audited and you lose your binder full of information, they're going to be able to reproduce those reports for you that have basically proven what your numerators and denominators were. But beyond that, the proper documentation needs to go into, have you audited your documentation to make sure it's very clear? If you claimed an exclusion, did you write down why you claimed the exclusion? Too many times we audit a practice and we end up finding out that they claimed an immunization exclusion. They ran their meaningful use reports. The meaningful use report showed 0 during the reporting period, but then when they're audited, that's not acceptable documentation for the auditor. And so then the new person who's there 3 years later says, we're doing immunizations now, so I have no idea why we didn't do it back then. And there was no statement recorded. There was, just nothing within the files that said why they were claiming an exclusion then. So it's just, and the reports aren't enough for the auditors. You have to have that statement from the providers to support it, that it was out of scope of practice, or for that 90 days they chose not to do it, things like that. And, so that's it. You just have to make sure that you go through measure by measure, objective by objective, and look at your numerators and denominators and have a brief paragraph describing why this is appropriate, why you think it's accurate. That is the best way to document this process. It's tedious, but again, it is the easiest and quickest way for you when you get that audit letter to just simply send it off to them and, get back from the auditors a message that says you've completed all the requirements that we're asking for, the money will be heading your way.
Can you tell us a little bit more about mock audits? I mean, it sounds like part of the process that you're describing is kind of like an audit, but tell us a little bit more about that if you could.
Yeah, you bet. So, we do what we call, because nobody likes to even do mock audits, it seems. Internally, it kind of gives people hives and they start itching and breaking out in rashes. But, so we always say, do audit assurance. That's what we call it. And we'll come on very critically, and we'll take a look at documentation, and we'll say, okay, your CPOE measure seems to be good, but, you're a certain specialty practice and you excluded one of the 3 vital sign measures. And you stated that it's out of your scope of practice, but why is it out of your scope of practice? And we ran into this with radiologists. Radiologists would say certain measures and objectives didn't apply to them due to their scope of practice. And I would say that's perfectly acceptable. If you can prove it's out of your scope of practice by not seeing patients, basically getting data together that shows that those encounter types or again, immunizations, you don't provide them, seems to be very straightforward. But unfortunately, CMS has data that shows that perhaps radiologists did say that it was in their scope of practice, and they did report on that measure. And CMS has that broken down. I mean, by specialty, they can see which specialists are meeting all the core measures, and then which of the menu measures they've chosen. And so when you state as a radiologist it's out of your scope of practice, but then 20% of radiologists out there actually attested to that menu set item, it's a question. And the auditors are going to ask about it. So just make sure that when you go through this audit process, this mock audit, you very critically look at what it is you're doing and answering for every single measure and objective, and play the devil's advocate. Is this enough? And that's what we do. That's what a lot of groups out there do, with their clients, or internally, especially large health systems do this. And they'll sit down with their meaningful use leader. They'll have an outside team come in, take a look at their reports, take a look at their documentation, and state, this is insufficient. The security risk assessment is a great example. We have seen many security risk assessments delivered by an IT company, but the only thing that the clinic gets is the executive summary at the end. And the auditors are not going to accept that. I'll just tell you right now, and I know we're going to talk about that at the end, but they're going to want to see what things were investigated, what deficiencies or gaps were identified, and they're going to want to see the mitigation plan and the steps you're going to take to reduce those deficiencies. Whether or not you correct them immediately or not, they're going to want to see all of that detail. And a lot of times through a mock audit, you can uncover those deficiencies before an auditor does, because they only give you 30 days. If you have a deficiency as part of the audit, you have 30 days without, you can try to request more time, but the auditor is under no direction to necessarily give it to you or not. And so by providing a mock audit, you can hopefully shorten the time that it takes you to figure out what's wrong, correct that, so that when an audit letter does come, you're ready to go and you can easily comply within that 30-day window.
That's a great point. Time will be short if you actually are audited.
Right.
So what's something providers need to keep in mind when it comes to cloud versus on-site EHR technology? I know there's a real mix out there of folks. A lot of people have moved to the cloud, but a lot are still using client-server technology.
Yeah, and this is great in terms of not so much because, obviously you've got an IT risk assessment, so you need to make sure that your cloud vendors, regardless of whether or not your EHR vendor, I know some larger practices actually have another company hosting their servers for them. So you need to make sure that they're a good BAA, a good BA partner with you. You've got a BAA on file, that they are following all the HIPAA rules and regulations, and you can identify that in your risk assessment. But also cloud vendors, as I mentioned earlier, they have to make changes to their system that impacts all of their clients. Because traditionally, when you move out to the cloud, you're sacrificing some of your customization capabilities because they're delivering one product to thousands of clients. And that poses challenges when, for instance, with the, the wonderful Flex IT rule that allowed people to do the 2011 combination 2014 certification due to problems with implementing direct messaging and things like that. Well, we had a lot of cloud-based clients that were forced onto the 2014 version and had no capability to roll back to the 2011 version. And where this comes into being an issue is some of those clients also discovered at that point in time, once the versioning changed to 2014, once the canned reports went to stage 2 inside of that cloud-based system, that it became very difficult for them to go back to the 2011 certification requirements, attestation requirements, I should say, if they needed to rerun the 2011 reports if they were ever audited. And the vendors came out and said, we can't do it. We've updated our reporting engine. There's no way we could go back and run you a report based on the 2011 stage 1 criteria, which we all know is now different than the 2014 stage 1 criteria. And so those are things to think about if you have a cloud vendor. Really go through your processes, workflows, reports. Think about 5 years from now. Do you have the data stored locally, even though you're using the cloud, so that you could survive an audit if and when it comes? On-site is much more related to privacy and security. The risk assessments really need to focus on your processes internal to this equipment. We have a lot of times as people move to stage 2 that they end up having to bring on a patient portal, and they're hosting that patient portal now basically on a server that's located on their premises, which means you don't have outgoing only traffic, for your internet. Now you've got incoming internet traffic, and the security ramifications of that, not necessarily are huge, but it takes someone who is very experienced in IT to make sure that you are running in a very secure environment. And so it's not so simple as some of the EHR vendors will tell you, great, you're running an on-site system, we're going to come in, you have to buy a new web server, we're going to set it up with your portal, and you'll be good to go. Boom, done. Now, someone needs to look at that to make sure it's secure so that some hacker doesn't go from your web server to your internal server, and starts exploiting your financial data in addition to patient information. So just make sure that your IT companies that support you or your internal IT on these on-site engagements truly understand your systems and how they're being utilized internally so that you, if you're ever faced with an audit, can prove that you have accurate documentation that's comprehensive for your entire facility.
All right, well, on a related subject here, what should providers consider when it comes to technology management?
Well, again, one of the things that we found in doing our mock audits, our audit assurance engagements, is that a lot of the IT companies that many small provider practices have engaged with have never signed a business associate agreement. They don't know what HIPAA is. They have no idea why they're being requested to do a risk assessment. When we get involved and we start to explain HIPAA and what it is for under meaningful use they're required to provide, a lot of these IT companies will actually back away. I've had this happen more times than I can count, which are like, whoa, that sounds pretty scary. We don't have anybody who can do that. And now you've got a provider who's left basically hanging out to dry. They're paying, maybe $300 a month, $500 a month, maybe $1,000 a month to an IT company to support them for Tier 1, Tier 2 help desk, break-fix issues, things like that. However, when it comes to the IT risk assessment, these companies have said, no, we're not going to do it. So whoever your IT support is, you need to go over the IT risk assessment portion for meaningful use. And you need to make sure that they feel comfortable doing that and that they're willing to roll up their sleeves and basically get their hands dirty by coming on site, investigating, what devices do you have? Do you have a bring your own device, a BYOD policy where doctors are able to come in, use their iPhones and their iPads? How are those being secured? Because some of these companies, especially if they're large national companies, what they'll say is that, well, we're under contract we're under contract to support your PCs, and that's it. And so we'll do a risk assessment, but it's only based on the PCs in your network and maybe your server. Well, that's not going to cut it, because your doctors are using iPhones and iPads also to access patient care, and those things have to be assessed. So understand who's supporting your technology, understand your service levels, agreements with them to know how deep in your organization they're willing to go. And if you need assistance, keep in mind that when you see somebody say we're a HIPAA certified company, as we've always talked about on webinar after webinar, there's no such thing as HIPAA certification. You know, people can say that they understand HIPAA, people can say that they're in compliance with the HIPAA, but the government doesn't have a HIPAA certification program, you know, in terms of IT compliance. There are a lot of certification programs to show that they've been educated on HIPAA, but to say that I run an IT certified, HIPAA certified environment is really misleading. So you really want to question your vendors when they're trying to say that their IT environments are HIPAA certified.
And it's something that a lot of products will advertise as being HIPAA compliant. It's really meaningless. It doesn't mean anything to say that a product is HIPAA compliant. How is it deployed and actually used?
Correct. And especially if it's on-site, you know, for you, because you really need them to be able to touch your equipment, either virtually, because there's a lot of great software out there that will, you put a little agent on somebody's desktop, and it will suddenly go out, and everything and anything, printers, laptops, phones, the iPads, you know, everything that's connected to the network would be discovered. So you have to make sure that they're at least doing that, if not also showing up and doing a physical workaround. And these are best practice, and these are things that the auditors are going to be looking for. And it sounds expensive. It doesn't have to be expensive, but you have to invest in someone who's knowledgeable about IT and knowledgeable about the way this moves forward. And I have to say, as an old IT director of a 10-site cardiology group, I feel for the providers who are running a small business and really understand that this is a cost impact to them. But anymore, I always try to steer the conversation away from, you're not doing this just for meaningful use. You really aren't. I mean, take a look at all of the credit card breaches that are occurring across the industries, healthcare, banking, obviously retail has been very big, but people are wanting to get to your financial information. So when you invest in IT, here we're talking about it under the auspices of meaningful use audit, but anymore, this has to be a basic cost of doing business because there are people intent on doing you harm. And when we also talk to, obviously, providers who say, well, that's why I'm not going to participate in the program, it's like, well, wait a second, don't you have a credit card service? Don't you have online patient scheduling or a practice management system? So even if you're not using a full-blown EHR, you have an electric system. You know, it could even be your PACS system. And that's an electronic system. And if it's hooked up to the internet for vendor support, it's hooked up to basically a highway that potentially someone who wants to do harm could discover and do harm. So you have to make sure in today's environment that you're meeting your IT requirements, not only for meaningful use, but also just best business practice anymore.
Absolutely. Just to add to that, you know, the FBI issued its private industry notification in April saying that healthcare providers have the most highly sought data by cyber criminals because it's so complete, and yet healthcare is badly behind other sectors in protecting that data. And, you know, the OCR published something a couple months ago saying that in the last 4 years there's been 125,000 breaches of provider records. So, I mean, that's just an incredible number of breaches. It's really not a safe environment to take your security for granted in.
Yeah, and again, you know, for those providers, I always just keep going back to it. You know, we had a breach just recently in the Omaha, Nebraska area. It had zero to do with electronic, you know, so breaches occur on paper as well. A secure shredding company came, they picked up records. It happened to be just like it always is in the Midwest, a very windy day. The door to the back of this truck blew open, and thousands of records blew across the street.
Oh.
You know, so I mean,
what a disaster!
Yeah, so I mean, this is not just related to IT, obviously, and risk assessment. It goes across paper, but you know, for the Meaningful Use Incentive Program, as we're talking about it here, obviously we're talking about IT and securing our electronic records, but it really does go beyond just PHI. It goes into your financial data, if you're storing credit card information, all of that good stuff. Even your own personal employee payroll files.
Sure.
You want to make sure all that stuff is buttoned down.
And I think it's great that you mentioned BYOD, because I think I saw, I think it was from the Ponemon Institute, that something like 90% of providers now allow BYOD, but obviously that's a security risk you need to think about.
Absolutely. And don't let anyone within your organization, I don't care if it's a front desk person who says that they're savvy on social media, all the way up to the founding provider, strong arm anybody to try to get around these rules. It is something that everybody has to take seriously, and if someone doesn't want to take it seriously, you should seriously consider letting that person go for the health of your company.
Well, what are some common failures then that you see out there in the field?
Unfortunately, these repeat themselves time and time again, and we understand the reasons for it, especially, our bread and butter in a lot of ways are rural provider practices, 1 to 5 providers, medically underserved areas that just are financially disadvantaged to begin with. And a lot of times it's decision by consensus. And without a single person driving what needs to be done for meaningful use, you may ultimately still come up with the right answer, but just not within the time frame necessary to appeal an audit or to even attest on time. And so you really need to identify a person who's in charge. But the problem that many practices run into is that they are already overwhelmed in their current, normal day-to-day job functions. Now you're throwing meaningful use on top of them. And this is not as you well know, Brian, this is not a small responsibility. It's not something that you can just go, all right, meaningful use, no problem, I got it, it's done. No, there's thousands of pages of regulations between stage 1 and stage 2 that people have to be knowledgeable about. You have to understand how HIPAA comes into play. You have to understand what your business associates are required to do. So all of this stuff, is the foundation. And then, oh, by the way, on top of it, the reason we're doing this is to capture data to actually improve patient care. And so that's what that's why you need to have one person who's monitoring this and really keeping the ball moving forward so that you can get past documentation and really move as fast as possible into improvement and getting, the wins out of what meaningful use was supposed to be all about. And a lot of times that's difficult, especially for small practices. No physician champion or executive oversight. Again, we've had a lot of one-doctor practices who are our clients. They have 2 part-time MAs. The physician is the champion, but they're struggling to do everything themselves. Well, as we move up to the 300 provider practices, you can have an MD champion at each site. You can have an MD champion on the steering committee. But where we've seen problems is that those champions are not vocal. They'll sit in a room with their peers, and the peers will basically short-circuit the entire process, and the MD champion will not stand up, confront them, and basically, say we have to move forward. So make sure that your executives, make sure your MDs are all in. They have to be. This is for the health of your practice. And so, again, we just see that too often. The risk assessments, a lot of times this ends up going into being no fault of the practice. They paid an IT company to come in and do a risk assessment. They're given an executive summary, which we now know is not good enough for documentation. You need to see the templates that they used in the background. You need to see the mitigation report, the remediation report, the deficiencies. And sometimes those IT companies didn't document it well enough. And so, unfortunately, the practice then gets dinged in the audit. So anytime you have a contract with an IT company, whoever they are, your normal 9 to 5 IT company or an outside quote-unquote expert, make sure that you get into the contract that if their documentation ultimately is not enough to meet what an auditor is looking for, at the very least, you can recover the cost of that service. A lot of practice or a lot of IT companies may balk at that, and you may not be able to get that, but it's definitely something you should at least be asking for. No public health reporting data captured state by state across the United States, you know, especially in 2011 to 2013, public health registries were in flux. Some were ready to accept immunization data, some weren't. Some were ready to take it online, some were only paper. Some wanted syndromic surveillance data, almost all didn't, unless you were a hospital. And so you have to make sure you document it very clearly, your communication with that registry. If you did a test, you should be seeing emails back and forth between you and the registry. You know, if you simply did a phone call to them, that's not going to cut it when it comes to documentation. I believe you, but I'm not an auditor. The auditor wants to see a paper trail. So whether or not you get an actual postal letter or an email from that agency documenting what was determined between you guys and whether or not your test was successful and now whether or not you're doing successfully ongoing transmission, make sure that that is captured. Good intention documentation versus reality. I put this in here because a lot of times we know that providers have documented everything they could think of, and it's just not sufficient for the auditors. Because again, how do you know what an auditor is looking for if you're a practice basically unto yourself, you haven't really looked outside of the walls of your practice for assistance, you've done a best faith effort to try to go measure by measure and do, you know, really review your objectives, and then you submit it, and then they come back and basically rip apart what it is you've sent in. That's tough, and it really is a de-incentivizer for a lot of practices. That's usually when we get called in, and hopefully we can right the ship and get everybody smiling again and move on. But there are a lot of companies out there, again, you know, that provide these services. But even beyond the companies, look to your peers. Again, as we talked earlier, you know, I mean, thousands of providers are going through this audit right now, and it's not something that you will typically have people advertising unless they were successful at it. But contact your medical association to see if they have providers that they can refer you to. Contact your EHR vendor to see if there are, you know, other peers that you can talk to who have gone through a process of the audits on their system and things like that. So, you know, you have to make sure that you've not only reviewed your documentation, but a lot of times it helps if you review what you've reviewed with your peers, with outside entities.
Absolutely, and just to reiterate, you know, I think that it demonstrates the value of having a third party look at your what you would be submitting in an audit, because it's just a little bit too easy to say to yourself, well, you know, I think we've got this covered, we're in pretty good shape, because you know that you're honest and that you've got the right intentions, but you're not looking at it with an auditor's eye.
Right, exactly. And again, you know, the auditors are really good people. I mean, when we've talked to them or we've had interactions with them, they've been very clear and seem to be very understanding. You know, again, my God, right now there are over 2,000 audits occurring, so you know that when they immediately discount the data that you've sent them, odds are it's because they're inundated with data, and if your data isn't very clearly written and organized, they're not going to spend hours upon hours pouring through your reports to try to interpret them. They have to be as clear as reading A, B, C, you know, and everything has to make sense. So a lot of times when we work with practices that really did get it right, where they quote-unquote failed was simply that they just basically created a big, huge file and just, you know, blasted it off without really organizing it, creating nice summary pages that link, you know, appropriately and things like that.
You mentioned before that providers can appeal a failed audit. Tell us more about that appeal process.
Yeah, you bet. So yes, you absolutely can, you know, appeal a failed audit, and you know the really, you know, the hitch is this: is that if you didn't have appropriate documentation that you sent them the first time to the auditor should have wrote back to you and said, these are the documents that we need to see more of. This is what we need more clarity on. And if you weren't able to provide that, you really need to do some internal soul searching and say, is it because we didn't do it? You know, and so at the end of the day, if you didn't do it, don't appeal, because you're going to fail the appeal, waste a lot of people's time internally, externally. However, if you really did do it, then you need to make sure that you've got all of your documentation together. Again, go through a lot of the steps that we've talked about, because that's when you file your appeal, that's what they're going to want to see, is very clearly laid out documentation that refutes basically the finding of the auditor. And that's not just something that you could throw together a ton of screen prints and fire it off and say that that's all they need. No, you need narratives, you need screen prints, you need possibly receipts, you need letters from vendors, from business associates, from consultants, things like that. CMS, I put a link here, and so when everybody gets the slide, they can actually, see that. But, Google CMS audit, and CMS, you will see, has a nicely laid out document that talks about, the documentation that they're looking for and are required, that their auditors ask for, so follow it. And then get a lawyer. I definitely have worked with a number of lawyers. They get the process. They understand. The one reason I say, but consider their advice carefully, is this. Without exception, every lawyer I've ever worked with as part of an engagement with a client has always cautioned the client to only give as much as they, only give just enough. Don't just show all your cards. Well, unfortunately, in our experience, that's not going to cut it. The lawyers want you to kind of protect yourself by not overexposing, which I do understand. But we discovered through an engagement with one of our clients, they sent off just the HIPAA IT risk assessment executive summary, and that's when the lawyer said that's all you should give them, period. Because otherwise you're going to tell the auditor what all your IT vulnerabilities are. That makes perfect sense to you and I, but the auditor doesn't have a good idea that all of your systems were reviewed unless they see the process documents. And that's what they've been contracted to research, to investigate. And so just consider the advice of the lawyer with a grain of salt, knowing that the auditors want everything.
This is a question that I'm sure is on a lot of people's minds. Does the risk of an audit ever end for folks?
And a word, no. There could be, obviously, when the meaningful use program, if it ever terminates, obviously that's when this terminates. But even there's an expectation in the industry that even after the incentives are done, that you're still going to be audited because people have to continue to attest in order to avoid penalties. And so, that's the double-edged sword as we move out of the incentive phase, is that you're still going to have to pay both for your internal labor and possibly external experts to come in and make sure you're still, dotting your I's and crossing your T's, just so that you're going to avoid a future penalty. And it is what it is. CMS with MAC auditors and the RAC auditors, they very much are in this for the long haul to make sure that their program is not being taken advantage of. And we've seen how much fraud is out there. There's a CFO in Texas who got sent to jail for a lot of years because they falsified their meaningful use attestation documents. So unfortunately, it is a problem, and in our bipartisan environment of making sure that all of our dollars are accounted for, we don't ever see this going away.
So where can providers go for help?
So again, be honest with yourself. When you're faced with an audit, you get the audit letter. If you really didn't meet meaningful use and you thought you were going to sneak by without doing X, Y, or Z, and you have no way of finding documentation that never existed, then be honest with yourselves and obviously do the right thing. And that's the 0.1% of people out there. The 99.9% of people, you've done the right thing. If that's the case, first look to your vendor, see if they have resources that can help you. 800 of our clients went through an audit the past 4 years. Here's their best practices. I've attended a number of conferences for EHR vendors. Anymore, it's routine to hear their clients talking about the process. So possibly reach out to your EHR vendor, engage outside experts like ourselves, legal firms, CMS directly. They have experts, regional offices. If you're a hospital, contact your MAC, find out what they're hearing, your medical associations, etc. And then again, Don't underestimate the value of networking with your peers. As a matter of fact, that would be the first place I would go. If I was part of the MGMA, if I was part of a local association, if I was part of a big city, in rural parts of the country, the Rural Health Association in your state, network, and find out what people have done, what has been adequate, what they, lessons from the field, basically.
All right. Well, we've gotten to the end of the presentation. There was a lot of valuable information in there. If I was a provider, I think I would really have a much better grasp of what the audit process involves and what I need to do to get ready for it. Because, as you were saying earlier, Todd, it's really more a question of when than of if. So I hope this is valuable to folks. We've got time for questions and answers, and then we'll talk a little bit about how you can talk to Wide River if you do need some assistance with these or other HIT issues. But first, let's get to some questions. We've got questions from our audience already. If you haven't asked your question yet, please do feel free to ask now. All right, so this is when you were talking about needing a letter from the vendor. And the question is are you saying that that's a copy of the contract with the vendor, or what exactly are you talking about?
So this is interesting. So on a prepayment audit, it could be a copy of the contract. We actually have in Nebraska today a webinar that we're hosting with our state, Medicaid. And that's actually the #1 question that we're getting in the field is, for proof, can we simply upload the entire contract and just be done with it? Some of our contracts that we found don't have the version number and the certification level in the contract. And so what we're hearing, especially if you've gone through a value-added reseller, a VAR, to purchase your software, this is actually a quote from one of our clients who are currently undergoing an audit. Proof of access, which is here, it's the letter from the vendor. We are unable to verify the product version number utilized during the attestation period. An example of sufficient documentation would be a letter from the vendor stating the product version number that EP utilized during their attestation period. Some of the documentation you have sent previously was your EHR version and a date at the bottom with the EHR as a screen print, basically, is what they sent in. The screen print wasn't good enough because they can't prove that that was yours. As absurd as that sounds. And so what the auditor then requested is, we need a letter from your VAR, in this case, that's, it's basically legally binding. It says, yes, Todd Searls is our client. As a provider, we gave, we contracted with them to provide version 11.1 on this date. So that's what they want to see.
All right. What type of documentation, this person asked, do you recommend keeping in the binder? We're using an electronic medical record, but we should keep paper documents in case we happen to be audited?
Well, so I always use the term binder because it's quick and easy to talk about. We have a lot of people who keep electronic documentation, either copies of their reports on PDF. They've uploaded a Word document. The EHR is the electronic system, but if all you're doing is regurgitating the meaningful use report, numerators and denominator numbers, that's not justification for instance, on the yes/no measures. When you go into meaningful use and you go to a test for whatever year, it's, yes, no, that's not good enough. You have, especially if you said no, you have to document why you said no. If you're claiming an exclusion, your meaningful use system is not going to, your certified technology isn't just going to generate, a nice comprehensive report as to why that exclusion applied to you. You have to provide documentation for that. So I always just use the term, keep a quote-unquote binder full of information that's very logical and supports all of your decisions. But however you capture it, whether or not it's an electronic Word document that you're keeping in a virtual file on a server somewhere as your backup, you have to make sure you've got comprehensive information that clearly supports, especially in the yes/no measures and the exclusion measures for when you go to a test. And the reason that's so important is so that when you are audited, you will have plenty of time within that 30 days to simply organize that information into a very cohesive package that you can send off to the auditors.
So electronic documentation is fine, but you need to have a narrative element to it where you're actually explaining what you've done.
Correct.
All right, I think we've got time for one more question. This one's pretty straightforward. I searched for CMS guidance for EHR incentive audits, and I couldn't find anything. And I have to say to this audience member, it is not always easy to find things on the CMS website. That's an understatement.
Yeah.
Unfortunately.
Unfortunately, again, that's why I provided the link there, but I would be happy to, obviously provide that as well. I think what I did is audited CMS audit guide, and the second link is a PDF.
All right. Well, that should. They can get there if they're in a big hurry, and then, of course, the follow-up information, they'll be able to get to it.
Exactly.
All right. Well, okay, so here's one more comment. Well, I think we got time for this. I received the prepayment audit request. It asked for information regarding any other office of outpatient facility where patients were seen. We do see patients at the hospital. What documentation will suffice when they ask for the documentation for proving that?
I am so glad you asked this, and I apologize that we're probably going to run over a minute or two, but it is so critically important. If you run a multi-site practice that, is the EP, again, this is going to your individual EP that is being audited. So don't look at this as an umbrella for all of your providers. Focus on the one provider that is being audited and follow where they treat patients. We have a client that is currently being audited. They, as their primary location, they see about 90% of their patients at their primary location. That location has a certified EHR installed. They have 2 satellite clinics that do not have a certified EHR, but they see literally, 5% of their patients at those clinics. We were able to run a report as a practice management system that showed very clearly, 900 patients in the primary. I'm exaggerating here or underplaying it, but 900 here and 50 and 50. And as a result of that, you pull that together as a report. But if that's all you do and you send it off, that's not enough. This is where the narrative comes in. You need to explain very clearly that the 900 patients that you saw at that one location is the primary location that has the certified EHR. The other 2 are ancillary locations that do not. However, you have done an audit of your encounters and are 100% convinced basically that you captured everything. And so when you're talking about hospital, though, the question you have to ask, are those Part A Medicare services, or are they the Part B services that you've been contracted? Because obviously if they're Part A inpatient services, that doesn't go into the meaningful use incentive payment program. It's only the Part B charges. And a lot of times, it's too much to get into here over the webinar. Happy to follow up with you afterwards. But where we run into questions is Part B billing through hospitals. Method 2 billing is what it's called. Do you have a separate contract with the hospital that would impact this? Hospital sites are tricky for outpatient services or perhaps other Part B ambulatory clinic services. But the long and short of it is if your provider goes to multiple locations to see patients and that billing comes back into your clinic, you need to make sure that you've accounted for those locations in terms of total number of visits, and that you can attest that over 80% of your providers and encounters for the unique patient records, patient visits are kept inside of that EHR, the certified EHR.
Well, thank you so much, Todd, for joining us today. This has really been great real-world advice on what people need to know about audit.
Well, I appreciate the opportunity. Anything we can do to help, we're here. There's a great, partnership between Format Approved and a number of excellent resources out there. We'd like to consider ourselves as one for your clients. Absolutely.
So for folks out there who are looking for assistance with meaningful use or other health IT matters, Wide River is ready to help. Go ahead and visit them at www.wideriver.com. and if you're looking for more information, and they can provide that assistance to you. If you need training in meaningful use, PQRS, or HIPAA compliance, visit formedtraining.com to access our self-paced online courses. If you prefer instructor-led workshops, visit www.formedworkshops.com to see our instructor-led training. Visit formedapproved.com to learn more about our upcoming Learning Lunches. The Learning Lunch button, which looks like the lunch pail on your screen there, will take you to our upcoming webinars where you can learn more and register. Our next Learning Lunch will air December 2nd and has the title Protecting Healthcare Consumer Payment Information, which is one of the things we touched on today. Keep an eye on your email box and your homepage for other upcoming topics. And remember, we'll be sending out an email after this session with links to both the slides and the video recording. Thank you again for joining us today.